Hello everyone, welcome back to Oncopath Simplified. In our previous video, we have discussed about HER2 expression in breast cancers. Today, we will continue with the same series of HER2 and we will explore HER2 overexpression in gastric and gastroesophageal junction cancers. We will see how it differs from breast cancer and what to look for under the microscope. Let's first quickly recap whatever all that we have learned about HER2. HER2 is a human epidermal growth factor receptor 2 and it is a member of the EGFR family. So along with HER2, there are other members also in the EGFR family, that is HER1, HER3 and HER4. So as we know, this encodes for a transmembrane tyrosine kinase receptor and HER2 does not activate by ligand, right? It gets activated because of the dimerization. Whenever there is a HER2 gene amplification or there is a overexpression of this HER2 protein, there is going to be a continuous activation of downstream signaling, which includes the MAPK and the phosphoinositol kinase pathways, and because of this, there is going to be an uncontrolled proliferation. Now, what is the role of HER2 in gastric cancer and why is it important for us to know is because almost 10 to 30% of gastric and gastroesophageal junction adenocarcinomas will show HER2 overexpression. And like in breast, here also the HER2 will act not only as a prognostic marker but also as a predictive marker for the response of trastuzumab. Now coming to gastric carcinomas per se, HER2 positivity is usually more commonly seen in that of the intestinal type of adenocarcinomas and it is often more associated with that of well to moderate differentiation. And again coming to the IHC staining pattern, it's usually heterogeneous staining pattern within the same tumor. Like few areas will show very strong expression, few areas will show very patchy, minimal, faint expression. So this type of heterogeneous staining pattern is more common in that of the gastric cancers as compared to that of the breast cancers. Similar to the breast cancers, again in gastric cancer, there are two methods for testing of HER2. First is you have immunohistochemistry, which will test for the overexpression of the protein, and here we have scores from 0 to 3 plus. And again, the second method is an in situ hybridization, which will test for the gene amplification. If gene is amplified, we say that it is positive for HER2 expression. If it is not amplified, then we say that it is negative for HER2 expression. Which specimen is very much ideal for this HER2 study in gastric cancer? It's a biopsy specimen or a resection specimen, and these are preferred over the cytology specimen. The reason being, biopsy or resection specimens provide intact tissue architecture, which are very much crucial for assessment. However, if the cell blocks have been prepared from the FNA, they also can be used when the tissue is limited or the resection is not possible, provided that the cell block has adequate tumor cells and preserved morphology. CAP, ASCO also include FNA cell blocks because they are often the only samples which are available in the advanced or the metastatic setting. Again, the area that is selected should be the lowest grade morphology because HER2 overexpression is more frequently found in well to moderately differentiated areas of the tumor. Poorly differentiated regions or the mucinous components often tend to show a false negative IHC expression, that is weak or absent staining despite of the adjacent positive foci. Thus, testing on lower grade ensures there is a highest chance of detecting HER2 positivity and avoidance of sampling bias towards the areas where the antigen expression is lost because of dedifferentiation or necrosis. Again, in case of heterogeneity, more than one tissue block should be studied because if one block may show 3 plus staining while the other is negative, testing both of them will avoid false negative classification. Now let us say that you have tested more than one tissue block for the same gastric tumor because it showed morphologic heterogeneity and the HER2 results are not identical. So how to arrive at a final HER2 interpretation in this case? So we will have a stepwise approach here. The step 1 is to record HER2 IHC for each block separately. For example, if you have 3 blocks, block A, B and C. Suppose if block A is showing you 3 plus IHC score, that is strong, complete to basolateral staining in 40% of tumor cells. Block B is showing 1 plus IHC score and block C is showing a 0 or a negative IHC score. So here you have to give the score to each block separately. You don't have to average the scores. You have to treat each as a separate observation initially. After doing this, we will proceed with step 2. Determine if any block shows unequivocal positivity. That is, if any of these 3 blocks is showing IHC score of 3+, then the tumor should be reported as HER2 positive regardless of negativity elsewhere. Okay? If all the blocks are showing a score that is less than 1+, then it's HER2 negative. And if one or more blocks are showing equivocal, that is a 2+ score, then you have to proceed with in situ hybridization on that block. Now, why do we do so? It is because gastric cancers can show HER2 heterogeneous expression, and HER2 targeted therapy benefits the patients even if only the part of the tumor is showing strong expression. So in that case, whenever an ISH is required, we proceed to step 3. That is, you have to perform the in situ hybridization on the same block that showed strongest HER2 IHC expression. If in situ hybridization that block is amplified, the tumor is HER2 positive overall, even if the other areas are not. Then we will go to step 4, that is describe the heterogeneity in your report. In the next slide, we will see how to inculcate that in your report. And always remember step 5, never average out HER2 expression. That is, even if only 10 to 20% of the tumor cells are showing 3+ score on IHC, it is still clinically meaningful. Targeted therapy can still be beneficial in such patients. So we will never average out the HER2 expression. So in detail about the step 4, how to document when HER2 expression is heterogeneous in our report is, here I have given example report statement. Like, see, you can write as HER2 IHC is showing strong 3+ membranous staining in approximately 30% tumor cells in block A, while block B and C show weak to absent staining. Given the presence of unequivocal 3+ positivity in part of the tumor, the overall result is interpreted as HER2 positive heterogeneous expression. Otherwise, you can also say HER2 IHC shows equivocal 2+ membrane staining in block A and negative stainings in block B and C. In situ hybridization has been performed on block A and it shows HER2 gene amplification, that is HER2 17 ratio being 2.5, and therefore the tumor is interpreted as HER2 positive with heterogeneous amplification. Coming to interpretation of immunohistochemistry for HER2 expression in gastric cancers, so unlike that of the breast cancers, here complete membranous staining is not necessary. Lateral or basolateral staining is also considered as positive only, and the resection specimen and the biopsy specimens, they have different criteria for calling them as 1+ or 2+ or 3+ and so on. The mandatory criteria in biopsy is at least a cluster of 5 positive cells should be present to take that report into consideration. So coming to the IHC scoring of HER2 in gastric cancers, in the second column you have the criteria for the surgical specimen, and in the third column you have the criteria for the biopsy specimen. So we say that the IHC score is 0 when in a resected specimen there is no reactivity or membranous reactivity in less than 10% cells, or in a biopsy specimen there is no membrane reactivity in cancer cells. So we say that this is negative for HER2 expression. Again, we say that the IHC expression is 1+ when in a resected specimen there is a faint partial membrane staining in more than equal to 10% cells, or if it's a biopsy specimen, then more than equal to 5 clustered cells which are showing faint membranous reactivity. Again, 1+ score is also treated as negative. Coming to IHC score of 2+ in a resected specimen, when there is weak to moderate complete basolateral or lateral staining in more than equal to 10% cells, or in a biopsy specimen if more than equal to 5 cluster cells are present showing weak to moderate complete basolateral or lateral membranous reactivity. In this case, it is interpreted as the HER2 expression is equivocal and we need to perform in situ hybridization for coming to a proper conclusion whether the HER2 gene amplification is present or not. Okay, and IHC score of 3+ is when in a resected specimen there is a strong complete basolateral or lateral staining in more than equal to 10% cells, and in a biopsy specimen when there is more than equal to 5 cluster cells with strong complete basolateral or lateral membranous reactivity. Again, whenever the IHC score is 3 plus, then it is straight away positive for HER2 overexpression. Now coming to the interpretation of in situ hybridization of HER2 gene amplification in gastric cancers. In the previous session on breast cancers, we have seen how to derive this HER2 CEP17 ratio and how to calculate the HER2 copy numbers. So similar procedure we are going to use here, and whenever the HER2 CEP17 ratio is more than equal to 2 or the HER2 copy numbers are more than equal to 6, then the gene is considered to be amplified, and we say that the HER2 gene amplification is present and it is positive for HER2 overexpression. Okay, whenever this ratio is less than 2 or the copies are less than 4, then we say that the gene is not amplified and we say it is negative for HER2 overexpression. Okay, now there are borderline cases whenever the ratio is less than 2 but the copy numbers are between 4 to 6. So these are considered as equivocal, and again like in the breast cancers, we have to correlate this with the morphology and the IHC score as well. Now coming to certain pitfalls that we have to always take care while reporting HER2 in gastric cancers. First and foremost is heterogeneity. It is a very major issue, like some areas might show 3 plus scoring while the other areas might be completely negative. Second is poor fixation, especially near the mucin pools. So we always have to ensure good fixation. Again, like in breast cancer, here also we have to avoid misinterpreting cytoplasmic staining as positive. So here also membranous staining is only considered as positive, right? And lastly, the threshold for biopsies is at least 5 positive cells must be present to consider that reporting. Now again, why is there so much discussion about the HER2 in breast cancers gastric cancers is because the TOGA trial has established trastuzumab as a standard therapy for HER2 positive advanced gastric cancers, and it has shown better response and overall survival has improved in HER2 positive patients. Again, now also newer agents like trastuzumab-deruxtecan are being studied even in HER2 low gastric tumors, a concept that we have similarly seen in that of the HER2 low breast cancers. So to conclude, HER2 in gastric cancer is a prime example of how molecular pathology is directly guiding therapy nowadays. Recognizing staining patterns properly and applying them correctly ensures accurate diagnosis and optimal treatment decisions. Another brain teaser for you. I appreciate if you can comment the answers in the comment section below. So, during HER2 testing of a gastric adenocarcinoma, 3 tissue blocks are examined. Block A shows strong, complete membranous staining, that is 3 plus score on IHC in 20% of tumor cells. Block B shows 1 plus score, and block C is showing 0 score on IHC. So what is the correct final HER2 interpretation? A, HER2 is negative because the average of all blocks is less than equal to 2 plus. B, HER2 is equivocal and this requires in situ hybridization to be performed. C, HER2 is positive, report with a comment on heterogeneous expression. And D, HER2 result is indeterminate, repeat testing on all blocks is required. I will be posting the answer next week, but before that, I really would appreciate if you can comment your answers in the comment section below. So I would know that whether my explanations are clear and proper or not. Thank you so much for your patient listening. I would be happy to answer if there are any queries, and also I would really appreciate if there are any suggestions regarding certain topics that you would like to be discussed on this platform, so that I will also prepare and read about it, and I'll try my best to present it in front of you in a simplified way. Have a great day. Thank you so much.